So here is the ABG. So I'm going to share the quiz that I use. Give me 1 second. Hey guys, Damon here. So I'm going to start off with the pulmonary. Let me see, I'm going to share that website real quick. Of course, you're going to start out with, okay, so your pH, you've got 7.35 to 7.45, okay, you'll drop the 7s and it's 35 to 45, then HCO3 is 2226, so you'll just do an up arrow, down arrow, up arrow, of course opposite, okay. And if you remember from chemistry, a down arrow is going to be for acidoses. Up arrow is going to be for alkaloses. So here is my template for answering all of these questions whenever they give you a PaCO2 or an HCO3. There's also another one, which is PaO2, but I really don't focus on that too much. It's a calculation for, you can calculate the pulse, the bolded numbers here. So pH of 7.3, PaCO2, which is 68, and HCO3 is 28. So with that, you've got a 7.3, which is low, a 68, which is high, and a 28, which is high. Okay, so you'll go up here. So you'll circle the arrows. Okay, so now you've got 2 on the top, 1 on the bottom. Okay, so our options are you've got metabolic, respiratory, you've got acidosis, or alkalosis. You've got uncompensated, and you've got fully compensated. So you're going to be able to answer a lot of questions on this. So with this, all you do is you just take your line and you draw all the way across. Okay, so you know that it's going to be acidosis, so we know it's going to be acidosis, and you always want to line up respiratory or metabolic with this line. So these two are on the same line, so you know it's going to be respiratory. Compensated means that the body's not doing anything to help you out. So you've got a 2 and a 0. That would be uncompensated. So you've got a 2 and a 1, which means your body's trying to help you out with using bicarb to help increase the pH of the body, but it's not doing a very good job. So this is partially compensated respiratory. So question number 2. Okay, so this is high, this is low, and this is low. Okay, and you just go up. So you got, so you got up, down and down. Okay, so again, you've got 2 and 1. So you just draw your line. So this is going to be respiratory alkalosis. So respiratory alkalosis. Let's see, question 2. This is a different question. Sorry, it's 7.0, which is low. Okay, so let's do this again. So 7.0, 23, and 12. So 7.0 is low, 23 is low, and 12 is low. Okay, so we'll do this again. So 7.0 is low, low, and low. So you draw your line. So this is going to be okay, that's D for me, and it should be good. All right, question 3. All right, I'm going to move on. I'm going to find one. All right, so this one is question number 6. So I don't know if it's the same or if it's random, but question number 6 is a pH of 7.39, PaCO2 of 27, and HCO3 is 19. Okay, so this one is within our range, so we're going to leave this alone for now. Okay, so I just put a line there. So 27 is low, 19 is low. Okay, so you go up here, low and low. So with this, you've got 7.39. So I tend to think of 7.40 being the perfect pH. It's right in the middle of this range. So it is still just a tiny bit low. Okay, so we're still going to circle that down arrow. So draw your line. You got 2 and 1. So this is going to be metabolic acidosis. So we know it's metabolic acidosis. Now, since we have a pH, C, and that is the correct answer. So I haven't seen a lot of questions with is this metabolic acidosis or alkalosis or anything like that, but it may ask you along the lines of patient is short of breath and these are your PFTs, your ABGs. So with this, they might give you like a 7.4 and 20, or 7.3, 7.3, 20, and then 28. So with this, they may give you the stem and they say the options may be what is the best for the patient, pursed lip breathing and all of this stuff, or breathing into a paper bag. So this one, you know that the PaCO2, so the partial carbon dioxide in the bloodstream, is low, which means that they're basically hyperventilating. So they're just breathing too quickly, and that's whenever you would use the paper bag to help increase that PaCO2 to bring them back to normal. So moving on to the Glasgow Coma Scale on my paper. So this is exactly what I'm going to write on my paper as soon as I sit down to take the test. Okay, with this, 1 is always none. So you've got E, V, M. So this stands for eyes, verbal, and to pain. So this means that you would give a patient a 4 if they can open their eyes and move their eyes around spontaneously. If they only open their eyes to sound, you give it a 3. If you pinch them and they open their eyes, then that's a 2. And if they don't open their eyes at all with pain, stimulation, or with sound, it's going to be a 1. So verbal is going to be oriented. So A and O times 4. 4 is going to be confused. So they make sentences, and the sentences kind of make sense, but they're just confused. You're going to give them a 4. A 3 means that they just say random words. A 2 is just sounds. So nothing is coherent. They don't make any words or anything like that. So you give them a 2. And of course, a 1 is they don't speak at all. Motor is obeys commands. 5 is localized. So if you pinch them on the bicep, they move their arm, something like that, some kind of reaction. 4 is going to be normal flexion. So then you've got abnormal flexion. So this one would be a decorticate. Which is flexion. So on the test, they might ask you you walk into a patient's room, they are in this posture, they give you this posture, and they may ask you decorticate, or they might ask what number on the Glasgow Coma Scale motor portion is going to be adequate for this patient. So this is going to be 3. So this is abnormal flexion. This is decorticate. And then this is going to be abnormal extension. So this is decerebate. So how I remember decerebate versus decorticate is there's so many E's in decerebate, that stands for extension. So one thing, whenever you're writing over and over and over again, you get these shorthands. So these 2 shorthands here are that equals flexion, which makes sense. It looks like you're bending the arm or the leg. And this is extension, which again makes sense because you're straightening the leg or the arm. So with that, you should be able to, if it gives you like a score on the Glasgow Coma Scale, so you can always add all this up. So this is a 15 is a max, or a 3 is a min. So if you write all of this, there's so much information here that you should be able to answer the 2 or 3 questions on the licensure exam. So there's not going to be a ton on there, but every little bit helps, right? I'm just going to memorize 6. And so far, it's done pretty well for me. There was one question about diuretics and swelling, which with a protein level, and I didn't get it right, but that's going to take way too much studying for me to memorize. But white blood cells is going to be 5 to 10,000 per millimeter cubed. That is the that's what they've been using on the PET exams that I've seen, as millimeter cubed, but it is the same as milliliters. So if you remember from chemistry, millimeters cubed and milliliters is the same thing, but just so if you look at that, you're like, oh, you don't have to calculate anything. It's still 5 to 10,000 millimeters cubed. So then you got platelets, which is 140 to 400. Micro is 10 to the negative 9. I surely hope they don't give you some weird number like that, but just remember, if they do give you that, and if you've got, an extra 45 minutes on your test, you could run that calculation. But next is hemoglobin. And for this, I know that there is difference between males and females, but the board exam is really good about knowing that there's differences in between resources and references. So I just try to remember 12 to 17, and I haven't missed a question on it yet. Typically, I think females are lower, like 12 to 15, and males are like 14 to 17 or something like that. So just know females are a little bit lower. Then hematocrit, I kind of remember just around 50%. So I know that there's a range. but I didn't memorize the range. I just put about 50%. So 41 to 50 for men, and 36 to 44 is for females. So I would just remember 40 to 50%. They're not going to give you something like 37%. Pretty close. To 45, 35 to 45. So sodium is going to be your 135 to 145 range. And the potassium is 3 to 5. Now this is a very tight range. So if they do give you something in the 1 or 2 or the 6 or 7, know that that is going to be abnormal. That's pretty rigid there. So that is the lab values that I'm going to remember. So now we're going to go to the eye muscles. So you've got eye muscles, and I've had a few questions on this, torticollis questions or H-test questions and stuff like that. So with the eye muscles, you've got your cardinal planes, your 6 cardinal planes here, and the mnemonic is I-O, Sir, Martin, Irving, some, lard. Okay, and this stands for oblique. This is going to be superior rectus, which is SR. MR, which is going to be medial rectus. IR is going to be inferior rectus. SO is going to be superior oblique. LR is lateral rectus. So with this, you've got the nerves, which start at the top left, 2, 2, 2, 2, 4, 6. And then the 2 S's are intorsion. And the 2 I's are intorsion, or extorsion, sorry. So extorsion is the I's, intorsion is the S's. So that is all of the eye muscles, and of course to go to the left eye, what you'll do is you'll just mirror this. Okay, so I always start with the right eye, the patient's right eye, and then I normally don't write the left eye, but you can. But if you do, you would start here. Okay, so this is IO, so internal oblique, superior rectus, medial rectus, inferior rectus, superior oblique, and lateral rectus. Okay, same thing. So these are going to be intorsion, same color, but doesn't mean there won't be one on Thursday. So there's that. There's the mnemonic and how I'm going to write the eye muscles. And there was a couple questions about it for the H test, which we'll go over in just a minute. And there was a couple questions about torticollis, what cranial nerve can cause optical torticollis. So of course I wanted to go for the accessory nerve, because the accessory nerve and optical nerve. So I think it was actually cranial nerve 6. All right, so H test. So I'm not going to write this on my paper just because I know it, but you guys need to laterally with the right eye. That is going to be testing the lateral rectus. Now, if you pull the eye laterally, and then you go up, your first instinct is to say, oh, it's the inferior rectus. It's not. So the problem is you've got your cardinal plane and your eye goes this way. Your eye goes this way. This muscle, okay, the inferior oblique is actually on lax, which means, okay, so same concept, but we're going to go down. So you're going to go lateral, which is the lateral rectus, and then go down. So instead of using the superior oblique here to bring the eye down, you're actually going to use the inferior rectus. Same thing on the medial, so right eye, medial side, this is going to be the medial rectus. To go up, it's not going to be the superior rectus because that's going to be active insufficiency of the superior rectus. So you're actually going to use the inferior oblique there. Then to go down, you're not going to use the inferior rectus because it's on. Again, it's going to be an active insufficiency. So you're actually going to have the superior oblique to test the eye muscles. So this is the right eye H test. So if you have a question on there, you've got it. All right. So just checking the stream. Well and quickly. So you'd want to save your time for questions that you want to spend a lot of time on. And typically whenever I've been going through it, I've been having an extra 15 to 20 minutes per section extra. So every time that I have in between sections, you can take that break. It just says an unscheduled break. So if you're done with the first section and you've got 20 minutes left, thing like that, go outside and stretch for a minute. Go use the restroom. Like they're not going to penalize you for taking that unscheduled break. But you have to be on that section between section 1 and section 2 on that screen that says this is your unscheduled break. You can take it, especially if you've got 20 minutes extra on the first section, or if you've got, you know, the second section, you'll have your scheduled 15-minute break, which means that your overall time stops and you got a 15-minute break. So I plan on taking a break every section. So after the first section, going into the second section, I'm going to take a break. I'm going to stand up, I'm going to walk around and all of that. And then the third section, of course, I'm going to take it again and stretch. So do it in between the 50-minute section or the 50 question sections. So you don't have to take an hour, and carrying over that hour, it doesn't start over. You get 5 hours to take 250. 1, 2, buckle my shoe. 3, 4, kick the door. 5, 6, pick up sticks. 7, 8, lay them straight. Okay, so buckle my shoe. This is going to be, of course, your Achilles. Kick the door, which is your quad, so your patella. Pick up sticks. So to pick up sticks, you have to use your bicep. So this is the bicep. Lay them straight is elbow extension. So this is going to be your tricep. Okay, and you should know what level. So this is the sacral level. This is the lumbar level. C5, C6, C7, C8. So again, just take up a little bit of your space on your paper and you can write that. It's just quick. Bicep, C5, C6, done, and move on so that you can save your time for your break, because if you know the negatives, then you know the positives just by matter of elimination. So your ionto, so you've got your negative, so you just got to remember DACAs, D-A-C-I-S. So this, of course, is dexamethasone, pardon the spelling. And then this is acetic acetate, acetic acid, acetate, same thing. Chlorine, iodine, and then salicylic. So with dexamethasone, this is going to be for inflammation. Acetate, so if you remember from chemistry class, acetate is your vinegar or acetic acid, so that's going to get rid of all of the limescale, calcium, rust, stuff like that. So your CLR that you buy in the store is just glorified acetic acid, which is vinegar. So this is going to help with calcium deposits. So if it says anything about like supraspinatus tendonitis, and I need to go over that supraspinatus tendon, and it may say like which electrode would you apply the medication for Achilles calcification or anything like that. So then of course you'll know it's negative and it's going to be acetate. So chlorine, let me pull open my paper. So chlorine is for, sorry, chloride is for sclerotic. So that's going to be on the skin. So I kind of think of whenever, if you've got eczema or psoriasis or anything like that, whenever you go to this pool, the chlorine messes with your skin, so then you'll use it for like sclerotic plaques and stuff like that on the skin. And then iodine. So iodine is for scars. How I remember that is whenever they make the scars for a surgical incision, so they cut your arm, they use iodine to prep the skin. So we're going to use iodine to get rid of that scar tissue there after the scar is already there. So iodine's for scar, and salicylic acid. Salicylic acid is for inflammation and plantar warts. I haven't seen this one on any of the on the tests that I've seen. So if you guys have, go ahead and let me know, but I haven't seen this. This is for inflammation, and I think cheat sheet that I made for modalities. Of course, here is where I'm working right now with the iontophoresis. So with this, you're going to have 40 milliamps. So if you just remember 40 milliamps, you'll know what the current amplitude and treatment time is. So if you use 4 milliamps per minute, you're going to use it for 10 minutes. Or if you use 1 milliamp, you're going to do it for 40 minutes. So I'm going to leave this up and I'm going to take a quick break and I'll be right back. So let's see. Next, I'll wait for that. So the rule of, so I'll scroll through here and we're going to go through all of this later at a later time. But I haven't seen any questions on edema or tissue healing. There was a question on tissue healing, whether it was direct current versus alternating current. And so the skin is acidotic and the wound bed is alkalotic. So whenever you're looking at a wound, you're going to give it the negative lead on the wound bed here, and you're always going to use with direct current. So I think that's all the questions that I've ever seen on that, was whether it was negative or positive in the wound bed, and whether it was HVPC versus alternating current. So high voltage pulsed current, which is HVPC. So I think that's all that I've seen on that. There's been a lot of NMES questions, so we'll go over that. So what I'm going to write on my paper on Thursday is just NMES. So that's going to be 35 to 80 pulses per second, and then 125 to 200 microseconds. So if you look here, 125 to 200 is going to be for small muscles, and then 200 to 350 is for large muscles. Small, and then 200 to 350 microseconds for large. Okay, so I'll probably write that on the paper just because I do not want to try to memorize that. So I'll look at this right before I walk in. So 35, 80, 125, 200, 300, 350. So you can pull in like 35 to 80, and then 350, and then 125. So you really just need to remember four numbers. So 35, 80, and 35 and 350 are similar, so you should be able to get kind of close. And you know the higher the 350 are for larger muscles. All right, moving on. So let's go to the Ranchos Los Amigos scale. So with this, I haven't seen any questions on a patient who scores an 8 on the Ranchos Los Amigos scale, or what is appropriate for a score of 4 or whatever. So we'll go over that next. Okay, and then after this, we'll go into the limp scales, burn scales, pressure ulcer scale, rule of nines, and then the Freyet's laws. So, and then 1 through 10. Okay, so just like a 1 on the Glasgow Coma scale, which is here, so 1 is going to be none. Okay, so that means they are comatose. So we've got, let's go a different color. So none. So a 2 is just going to be generalized response. So a 3 is going to be localized response. And as you can see, this is very similar to the Glasgow Coma scale. It just pulls in everything into one scale. So next you have CA, PA, PA, and PA. So you can go 3 C's, an A, and 3 P's, and AI, A's all the way down if you want to do that. I don't know how you want to try to memorize that, but I will pull up the Ranchos Los Amigos scale because I don't have it memorized 100% yet, but still got a day. So no response on 1, 2 is generalized response, 3 is localized response, so we're good so far. So this is going to be confused. See what they need and stuff like that. So this one is going to be, the next 3 are all confused. And it kind of just keeps going. So it kind of repeats itself. So this is inappropriate. And this is confused and appropriate. And then purposeful, appropriate, and these are all appropriates here, right? Appropriate, appropriate. It's 1, 2, 3, 4. Yep. So these are all appropriates here. Minimal confusion. This is wrong. 6. So this is response to commands. So obeys commands. This is minimal confusion. The next one is going to be an 8. So this is going to be depression. Function in daily life, which will help them count change back, to help plan meals and stuff like that. So they don't need any manual labor assistance. They just need a little bit of assistance to say, now hang on, you're giving the cashier a $5, and look at the cost. This is $17, so you need to give them a 20 and stuff like that. Just some of those mental things. Depressed. So an 8 is purposeful, appropriate, has functioning memory, responsive to environment. They need a little bit of help there. So that's the Ranchos Los Amigos scale. So I've seen at least one question per test. I think one question per test. It's pretty common to be seen there. So seems like the connection is not very good. You guys can go through and look at that while I'm working on the Sorry about that, guys. I think there was a setting off on the OBS. I've been having troubles with it this morning, so if there is a problem, just go ahead and hit me in the chat. I'll try to get it fixed. We'll see how that works. All right, so moving on. So we've got the lymphedema, burn, and pressure ulcer scales. So Haley Spann told me this one. I think she thought of this one for the lymphedema. And this one comes up very often. This one gets hit all the time on all of them. And then this is going to be burns. 2A, 2B, 3. Sorry. I'm gonna go deal with my dog. All right, sorry guys. So let's see. Let's go back to Haley-Span's lymphedema, the burns, and the pressure ulcer scales. So there are some similarities here, which helps. So with the lymphedema scales, let me pull it up. IT, thank you, Haley. So this is subclinical. So there is a problem with the lymphatic vessels, but it is reversible, okay? Or elevation. Now let's just do, I did elevation, decreases it, or you can do reversible. So if it says something like swelling is worse when the patient stands, but whenever they elevate the leg, it decreases, then you're going to automatically give it a 1. So you can think of leg, a 1 is a leg straight up and down, and it helps to flow it down. 2, which is I, which is irreversible. Or I put a positive stimmer sign, or it's hard, which means non-pit. Okay, I'm going to have skin changes. So I do a delta. So delta equals changes. If you remember from physics, delta equals changes. So I don't remember what a stimmer sign is. So a stimmer sign is literally so this is a positive stimmer sign. So if you can pinch the skin on the second phalanx on the foot, that's a negative stimmer sign. So you see how you can pinch the skin there? So you get a skin fold. A positive sign, which is for lymphedema, folded at the skin of the base of the second toe cannot be pinched or lifted. So you can literally pinch it and lift it up. If you cannot do that, that's a positive stimmer sign. So you're going to give it a 2 or a 3. So on the test, if it says positive stimmer sign, again, you're going to have a 2 or a 3. The delineation between a 2 and a 3 is going to be skin changes. So a 3, you're going to have skin changes with that. So you're going to have fibrosis or plaques or anything like that. So let me see if it's working better. All right, so that is lymphedema. So burns, you've got, let me pull up the burn scale. Which is different than the rule of 9s, which we'll go over that too. Burn stages. One question I saw on the licensure exam was you had a stage 1 burn, but they had an infection that went down, or a stage 2 superficial partial thickness burn, but they had an infection, so it went into the dermis. What would you give the scale? And I didn't think you could progress like that, because pressure ulcers, once you have a stage 3, you don't go stage 3, stage 2, stage 1, or anything like that. But a burn scale, you can't increase the stage. So if it does say something about you get an infection or anything like that, you can increase the intensity of the burn with that. I didn't know you could do that. So Let's see. So let's go to burns. So you've got first degree, which is superficial, different color. So this is just sunburn. It's what some people call it, just a sunburn. It's just on the top layer. You really didn't do anything. They shouldn't be coming into physical therapy for stage 1. So it's just the top layer. So it's going to be red, but no blisters. Okay, this is going to be a superficial, partial thickness. So this is going to be blisters and wet. Okay, these are going to be intact blisters. So if it says a patient has intact blisters, you're immediately going to go with the superficial partial thickness. Okay, so you've got 2B. I know that they don't really describe it like that. They either say first degree, second degree, third degree burns, and then some places or some references say superficial partial thickness, superficial deep. So this is only the top layer of the dermis, I think, and then this is the lower level of the dermis. So, sorry guys, I don't know why it keeps cutting in and out. And temperature, sensation, because you've burnt the top layer of that dermis, which is where all of these sensories are. And then, but you will still have pressure and vibration. So I think pain and temperature are very finite, so they need to be closer to the top of the surface in the dermis. And then third degree, which is going to be your charred, black, and no sensation. So then you've got pressure ulcers, which will go so the pressure ulcers, you've got non-blanchable, so 1, 2, 3, 4. So you've got non-blanchable. So you push on it and it does not change to white, it's still red. So that's your first indication of having a pressure ulcer. So 2 is going to be shallow. It could have slough on the sides or whatever. This is going to be just the epidermis. Three is going to be the dermis or the subcutaneous tissue. So they like to show a picture of a pressure ulcer, and if there's subcutaneous tissue, adipose tissue that is showing, it'll automatically be a 3. A 4 is, all you have to remember is bone or tendon is showing. So Then of course there's unstageable. So if it's covered and you cannot see anything at all, then it's going to be unstageable. All right. So rule of nines. So I don't write this on the page. I just remember it. You can write it on the page. All right, so next we'll be going over the rule of nines. So let's draw your little stick figure. So with the rule of nines, you've got 11 nines. So it's 9%. So if you've got 11 nines, that's 99. So you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then you've got 1 for the genital. You've got 2 on the back side, sorry. So 2 on the back side, 1, and 1. So then you've got 1 here. So that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So that means that the torso here is going to be 18. The entire arm is 18. Sorry. The entire arm is 9, 9. The front side of the leg is 9. The back side of the leg is 9. And then the back is 18 also. So if they ask you something about like the left arm is burned and the torso is burned, you know it's 18 and 9, which is 27. So whenever I'm sitting in the test, I just go through 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And then 1 for the genitals. I think that's it. That's all of my paper here. So that's what I'm going to write down for the paper as soon as I sit down. So I'll go over that again in a little bit just to reinforce it. But now we're just going to go over some of my study guides, some things I need to go over. So we've got Dr. Kumba. Okay, so this is the so this is going to be with the different styles of okay. I know this is Dr. Kuma, but I threw a Dr. Kumba with a B in there. So you've got drop arm, which is the radial nerve, because the radial nerve does contraction of the wrist extensors. You've got the claw hand, which is the ulnar nerve. And then you've got the median nerve, which is the benediction, or the ape hand. Okay, so median nerve, ape hand, or the hand of benediction. So the problem is these two look identical, especially with the picture, and it's not saying what you're doing or what you're not doing here. So with the claw hand, with the ulnar nerve, you know the ulnar nerve goes to the fourth and fifth digits here. So if you cannot make a clasp, you cannot clasp your hand, then you have an ulnar nerve. Okay, so you cannot clasp. Okay, versus the benediction or the ape hand, you cannot extend. Right? No, is that backwards? That's backwards. So this one, that worked, but it's backwards. So ape hand, you can't make a fist. So the median nerve I remember loaf, L-O-A-F, which are the lateral two lumbricals. So if you're standing in anatomical position, which is out like this, your lateral two lumbricals are your thumb and your index finger. O, which is opponens pollicis. A is abductor pollicis. And F is flexor pollicis. So median nerve is a medium loaf of bread. So these innervates, the median nerve innervates those four muscles inside the intrinsics of the hand. Of course, you're also going to have a lot of the flexors of the wrist, but these are the intrinsics of the hand. So if you have a problem with the median nerve, you're not going to be able to flex your fingers and you're not going to be able to flex your thumb. So Dr. Kumba, MBA, cannot make a fist. There we go. M cannot make a fist. That works. So if it says in the test that the patient is trying to make a fist and the patient looks like this, or the ape hand or hand of benediction or anything like that, you know that the median nerve is compromised here versus the claw hand. So they all look the same, as you can see here. But this one, they are trying to, with the claw hand, they're trying to extend all the fingers and they can't. So that's where they get the two fingers, the last two digits over there cannot extend. So that's part of the ulnar nerve. Versus the median nerve, if you cannot make a fist, then you've got the ape hand, which is the median nerve. That works. I've got a list over here. Some of the things I need to talk about. Oh, the one of the things that keeps coming up is the ulnar tendon. So, question may say something about what is the best position to palpate the supraspinatus tendon, or if there's calcification in the supraspinatus tendon, what is the best position for that? So, with ultrasound imaging, there is a position that you have to place the patient in order to get an image of that. And it is called something. Give me 1 second. So the position is internal rotation, extension over the back of the arm of the chair. So you think about it. If you want to check the supraspinatus tendon, so you've got your chair here, literally you're going to have the patient put their arm behind them just like that. And that's going to do internal rotation of the shoulder, extension, and you're going to be able to palpate that supraspinatus tendon there. So this right here is the position for that. And that's called something in ultrasound imaging, but I don't remember the name of that position. I think it's on Radiopedia. So scratching between your shoulder blades. That's a good one. Or reach back for your wallet. So supraspinatus, scratching between the shoulder blades. That's how you get to the supraspinatus tendon there. I know that is a common question on the PET exams. All right, next we're going to go over the cranial nerve testing. So everybody at this point in your studying, you should have a mnemonic for the cranial nerves. Mine's pretty rough, so I'm not going to share mine. Okay, so you've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and then you've got some say marry money, but my brother says big brains matter most. So these stand for, of course, you remember from A&P 1 10 years ago. So sensory, motor, both. Okay, so this is olfactory, optic, oculomotor, this is trochlear, this is trigeminal, abducens, facial, vestibulocochlear. So you've got the vagus nerve and the vestibulocochlear. To remember, an 8 is for vestibulocochlear. I always think of 8 looks like your ear on the side of your face, so I know that this is vestibulo. Glosso, vagus, accessory, hypoglossal. And I realized I made a mistake up here with all of these. These are not 2s, these are cranial nerve 3. Because the optic nerve reads it. 3, 3, 3, 3, 4, 6. I wonder how often I've done that. Oops, sorry guys. All right, so now to test all of these, of course the olfactory, these are the tests. And they never ask olfactory and optic and all that stuff, but they will ask for oculomotor, trochlear, and abducens. So this is smell, something like that everybody knows, coffee, peppermint, something like that. And then this is Snellen eye chart. This is, of course, this direction, that direction on the eyes. So 4, of course, is eye motion. This is going to be lateral because we know up here, if we go up here, cranial nerve, what are we on? 4, it's going to be down and to the right. So with the H test, it'll be down and in to test for the superior oblique. And then also this is for eyelid. So if it says something about ptosis, you know it's going to be affecting the oculomotor nerve. So ptosis is dropping of the eyelid on one side. So Bell's palsy and stuff like that. So trigeminal, so I always say it just like that, trigeminal. So that is going to be for chewing. And it is both, as you see here, it is both. So this is going to be chewing and sensation on the face. So eyebrows, cheek, chin. So you can have them, you can just touch their cheek and stuff like that. So cheek. Abducens 6. So this is going to be eye motions. All right, so facial nerve. So this is taste on the anterior 2/3, which I have seen that on the licensure test and the PETS and all that stuff. And also the facial nerve is motor, so puff out cheeks. With keeping your mouth closed. So this is the facial nerve, does all of the orbicularis oris and all of that for the mouth. I don't think that's right muscle. Anyway, it's the mouth muscle. So whenever you puff out your cheeks, but you can keep your air inside your cheeks. So if they try to puff out their cheeks and then go, and you're immediately thinking that the facial nerve is being affected. So that is the sensory and motor for that. Then you've got cranial nerve 8, which is hearing and balance. So Weber and Rhine test, they're not going to ask that, but that's whenever you put the tuning fork in front of by their ear, and they can hear it, and then as soon as they stop hearing it, you put it on the mastoid process, or you put it on their forehead, and then if they can still hear it, that's a negative test. If they can't, then it's positive, of course. So glossopharyngeal, that's going to be saying ah. So I think glossopharyngeal, glossopharynx, so that's going to be in the back of the throat. So that's going to be for saying phonation, so talking, and it's also going to be taste at the posterior 1/3 of the tongue. Okay, so the vagus, whenever you just say vagus, it sounds like you're gagging. So vagus, vagus. So that's going to be your gag reflex. So I think it also does some of the taste on the posterior third, but I haven't really noticed that with the testing for cranial nerves. I've always seen it with the glossopharyngeal's taste, because the vagus nerve, you want to make sure that you get that gag reflex, which we don't do. Also with phonation, so you have to have the vagus nerve to say ah also. So accessory nerve, this is going to be your sternocleidomastoid and your trapezius. So common question with this is torticollis. What cranial nerve is affected with torticollis? Like we talked about before, it can be cranial nerve 11, or it can be the cranial nerve 4 or 6 that brings the eye laterally. And then hypoglossal is tongue protrusion. So you tell them to stick their tongue out, and it deviates, you're thinking a stroke or a problem with the hypoglossal nerve. All right. So now we're 36 minutes in. I think it's time for a short break. Go outside, go get some sunshine. So we'll take a 5-minute break. So I've got a little timer here. I think I could do a timer on here. All right, so see you guys in 5 minutes. All right, guys, welcome back. So let's see, what do we got next? Oh, it's because of that. All right, so here's all the stuff we went over so far. Just to recap. So if you've missed anything, don't worry. I'll have to write it again and again and again and again. But so with this, with the eye chart here, with the H test, so we're going to take this and you're checking, so laterally, you'll check cranial nerve number 6. That needs to be a different, well. Cranial nerve 6. Going up, you'll check cranial nerve 3. Going up, you'll check cranial nerve 3. 3. Now this one, remember, superior oblique is 4, and this one is 3. So, whenever you're doing the H test and your right eye, of course we're looking at the right eye, goes medially and down, you're checking cranial nerve number 4. Okay? Versus you go laterally, you're just checking cranial nerve number 6. And then going superior, you're checking cranial nerve number 3, but with the superior rectus there. All right. So that so far, so one thing with the lymphedema, there's so many questions out there about long stretch bandage versus short stretch bandage. Long stretch bandage is never the answer with lymphedema. Okay, so long stretch bandage has a high working pressure and a high resting pressure. So what that means is the high stretch bandage is great for acute injuries of an ankle sprain or a wrist sprain. So your ACE wrap, your athletic trainers, if you're working on a football team and someone sprains their ankle, you immediately go out there and put some compression on it with the ACE wrap. So ACE wrap is a long stretch bandage. The long stretch bandage, what I mean by a high working pressure and a high resting pressure is even whenever the limb is not being moved, there's still a lot of pressure on that extremity or on that area. So it's trying to stop the swelling immediately. You're not going to leave it on for a long time. You're going to try to cut off the supply of all those cytokines into the joint so that you do not have as much swelling. So again, I say it, long stretch bandage is never the answer with lymphedema. A short stretch bandage, which is different than ACE wrap. So ACE wrap, it just keeps going. That's a long stretch bandage. ACE wrap, not ACE wrap, wrapping for lymphedema is short stretch. You just basically pull it and it's just a tiny little bit so that you have a low resting pressure but a high working pressure. Okay. Okay. So if you just Google short stretch bandage resting pressure, you're going to have a low resting pressure. So that means that whenever you have the lymphedema wrap that you wrap up the arm in the figure 8 or the circumferential, basically whenever the body is not moving, there's not a lot of pressure on that area. So it's low resting pressure, which means that it's just able to push that lymphedema through the body into the lymphatic tissues. So if you used ACE wrap on lymphedema, you're basically going to cut off the lymphatic vessels so it's not able to push that lymphedema back into the lymphatic vessels. So like I said, long stretch bandage is never the answer when it comes to lymphedema. All right. So that's one more thing off our list. So I'm going to be jumping around a lot today, but I'm just trying to get through some of the stuff. The last PET exam I took had efficacy versus efficiency. I'm sorry. Let me pull it up. I need to go with Herb's palsy. Efficacy versus effectiveness. So that was something that was taught in the evidence-based practice class, which if it was similar to our program, it was like semester 1 or semester 2, so I really don't remember all that. So efficacy is ideal situations. Okay, so efficacy is smaller, so you're only going to use it in a smaller setting. So it only works for this specific clientele, this specific company, this specific gym. So effectiveness is a longer word, so it can work in more diverse applications. So typically this will be, they'll say more like, so this will be like clinical conditions versus ideal, very specific conditions. So small word versus longer word. That's all I can remember. I doubt you'll have that on the exam, but maybe. So let's go over EKGs next. So this right here is my one-page study guide for the cardio exam 1. So we'll go through some of this here. So one thing to remember, I've seen this on a test, is this right here. So if it has any problem with the ST segment here, you're already thinking a STEMI or non-STEMI. So STEMI is ST elevation myocardial infarction. Non-STEMI is ST depression or T wave inversion. So if your ST wave, which is right here, if it's low or if it's long or anything like that, you know you're going to have a non-STEMI because it's non-elevated. Or if the ST wave is way up here, that means that you have a STEMI. So that was a question on the test that I missed because I completely forgot about EKGs. So I'm going to go over the EKGs real quick. So this is your ST segment, P wave. I need to go over how to calculate heart rate because I know that heart rate sometimes come up. So one box here is 0.2 seconds. So if you have 5 of these boxes, that's going to be 1 second. So you can count, you can memorize this up here, which is 300, 150, 100, 75, 60, 50, or you can measure, or if you can count the top. So that's one. Oh my God, sorry. PDF does not work very good with pen. So that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So that's 20 seconds. So that in 10 seconds we have 1, 20 seconds we have 2. So this is right around 60 beats per minute. So if it was right here on this beat, so you're going to be 60 seconds. So this is right around 70 beats per minute. Okay. And you can also do, I think, so many boxes are 10 seconds. That's pretty good. Huh. So what they say here, you can remember that. Or you can say 1, 2, 3, 4, and this would be 5 here. So you can take 300 divided by how many boxes are in between the top of the R wave, QRS, R wave, yep. So that's 1, 2, 3, 4, 4 boxes. So 400, so 300 divided by 4. You could do that. If you don't like math, you could just count it up and go from there. All right, so another one that you'll get is a PVC. So PVCs are very common in the licensure exam. So your PVCs here. So if it looks like this, or if you've got 3 in a row, I think 3 in 1 minute or less is classified as emergent. So you want to sit them down and contact the nurse or whatever. Um, so Kyle Rice has a video on YouTube that talks about PVCs very well. So I do like Kyle Rice's video on that. I'll put it in the link.
Entering the room, evaluating a patient in the acute care setting. The patient has a history of CHF, COPD, atrial fibrillation, hypertension, and fibromyalgia. Upon entering the room, the following image is displayed on the ECG monitor. What is the best course of action? So we got immediately stop the evaluation and call the nurse. We got B, which is assess the patient's blood pressure. C is activate the rapid response. And D is to continue with the evaluation while monitoring the patient's response to activity. All right? So let's go ahead, start at the top of the order, start at the top of the question. Nate is evaluating this patient in the acute care setting. All right, so the first sentence really doesn't have much going on, right? There's not much to really gather from the beginning of this. I mean, it's important for you to understand and recognize that we are in the acute care setting. And so there's different decisions that are made in the acute care setting when you're a physical therapist. I mean, when you're outpatient, you know, we either have the option to treat our patient or to not treat them. We can call EMS, we can refer them to their physician. Those are our options. But in the acute care setting, you have other options, right? You can call the code, you can refer to the physician and let the physician know about whatever. You can just contact the nurse, you can terminate treatment. I mean, there's a lot of different decisions. Okay, and so we need to be aware of that. We need to respect that there are some decisions and why we would make those necessary decisions, all right? So it's really important as we're continuing down this question. Now, it says that the patient has a history of congestive heart failure. All right, so that's important, right? The patient is having that congestive heart failure. We know that their heart is unable to meet the demands of the body. It's not able to pump out enough blood to meet the demands of the body, so that's important. Patient has COPD, so they have this obstructive lung condition, difficulty getting air out. Atrial fibrillation, so we know that this is a cardiac arrhythmia. All right, that deals with a quivering of the atria. And the reason why that's happening is because they're not getting very good signal from the SA node. They're getting all these signals from what we call ectopic foci. It's just different areas within the atria that are just sending these electrical signals. And so the atria is just like freaking out, just freaking. All right, we call that fibrillation. All right, atrial fibrillation. Then, so that's important. And then we have hypertension, which is high blood pressure. Everybody's pretty familiar with that. And then fibromyalgia, which we know is a bit of a rheumatic condition where a patient has myalgias, pain, these different tender points throughout the body as well. So it's characterized by that. Okay, and also fatigue is a major player in fibromyalgia. All right, so we have this list of all these different conditions, these comorbidities. And so now upon entering the room, the following image is displayed on the ECG monitor. And so what is our best course of action? All right, so before we go down, start dissecting and dominating this question, you have to look at the ECG reading. All right, what do we see here? So I'm gonna tell you something that I do, y'all. I'm gonna tell you something that I do, Thomas, Sarah, Tracy, great to see y'all tonight. You know what I do is I always start on the left side of the ECG or EKG reading, whatever you want to call it, right? And I always start there, and I know what my waves are. I know that there's a P wave, a QRS, and a T wave, and I know what they all stand for. We have to know that first. But when I start off on that left side, the first thing I'm looking for is my P wave. That's the beginning of cardiac contraction, right? And so I'm looking here, and I do see a P wave. All right, I do see a P wave, but it's kind of weird, right? If you really look at this, it's like I see one, but I can't tell if that's like 1, if that's 2, if that's 3. I don't know. It's just bumpy lines all the way across. Then I see a QRS complex. That's a big peak. That's cool. Then as I move into where I should see my P waves again, my T wave and my P wave, I see just a squiggly line again. There's not a defined P wave there. It's just like a squiggly line. So I'm like, I don't know about that. I don't know about that. That's not like a very true P wave that precedes the QRS complex. What is that telling me already? Well, it could be a AV node block. But no, I am getting a P wave. So it's not necessary to say that it's an AV node blocker, second degree or third degree. There's actually a bunch of P waves, it looks like. Well, what's that consistent with? That can either be an atrial flutter or it can be an atrial fibrillation. All right, well, let's continue down the line. As I get up to this point right here, all right, and I'm looking at that, I'm saying, okay, I definitely see some P waves. Again, it's like a squiggly line. It's not defined at all. And so already that's leading me to believe that, okay, what I'm looking at right now is atrial fibrillation, because the one thing about atrial flutter is that it's very consistent. All right, it has these P waves that kind of look like that, and they call it a sawtooth pattern, and then it has a QRS complex, and then another sawtooth pattern, and then I know my drawing isn't the best, but it's a sawtooth pattern when you're talking about atrial flutter. But atrial fibrillation, it's kind of like erratic all over the place. We got a bunch of P waves just popping up. So what am I really seeing here? I'm not seeing a PVC. I'm seeing atrial fibrillation on this ECG. All right, and now that I have an understanding of what's going on in this ECG reading, I need to determine, well, what is the best course of action given this clinical picture? So let's go down and start dissecting the answer choices. So we have A, immediately stop the evaluation and call the nurse. All right, so this is a good one. I like these questions right here, baby. And the reason why I like them is because it's like, ooh, do I stop the eval and call the nurse? My question to you is, well, why would we stop the eval? What is our purpose? Why are we doing it? So here's the deal. Atrial fibrillation is actually a pretty common condition for an elderly person who has congestive heart failure, all right, who has these cardiac issues. So atrial fibrillation is not an emergent condition, all right, and the fact that the patient had atrial fibrillation previously and now they're presenting with atrial fibrillation on their ECG, well, they have atrial fibrillation. That's what I expect to see. So immediately stop the eval, I would not do that. I mean, if this was the first time this patient had ever showed up with atrial fib, then I'd be like, all right, hold on a minute, we need to see what's going on, we need to stop, all right? But right now, the patient's had a history of atrial fib. I'm seeing it on the ECG. Why stop the eval? Why contact the nurse? There's just not a definitive reason as to why I would do that. I don't like A. I don't think that that's the best course of action at this point. All right, let's look at B. It can impact blood pressure, but B, I don't like it. Would I want to check the patient's blood? That the patient monitor with it, which is to be expected. Following on the heart monitor. Which of the following is
Sorry
the
guys, that
best
was the wrong
course of action? Now, for
video
those of you
for
on the podcast right now, you may have heard me pause a little bit, say the therapist notices following on the heart monitor, and that's because there's actually a picture that I'm going to explain to you here in a moment, so everybody has an equal opportunity for dominating this, all right? But let me go through the answer choices really quick. Answer choices are A, stop the exercise and alert the rapid response team. B, stop the exercise, place the patient supine and contact nursing. C, continue the exercise but reduce exercise intensity. And D is stop the exercise and alert the physician immediately. All right. So when you look down below on this question, you actually have an EKG readout. And there's multiple leads here. You see V1, V2, V3, V4, V5, V6. You may have seen this come up on one of your practice exams before where they try to plaster this EKG strip in front of you and say, go ahead and read that. All right? Well, that's exactly what we have here. And you can tune in to YouTube, check this out if you want to see it for yourself, but I'll go to describe what I'm actually seeing, and then, like I said, you can look at it on your own. So, again, you have all your strips here, and I'm going to pick out one specific one, though. All right, I'm looking at the middle line. It says V2 here, and as I go all the way over to the left side, I start to follow my way over. I do see a P wave. I see the QRS, and all of that looks just fine. But it seems like as I go out towards the ST segment and the T wave, it's like it looks like a freaking mountain. It looks super tall, and it goes all the way up, and it's a lot more narrow compared to the normal T wave. All right, and as you continue over, I just see that repeating over and over again. You see your P wave, you see your QRS, you see this tall, large T wave, though. And then it goes back into the next cycle. All right, so that's really what I'm seeing. That's what's sticking out at me, at least. Check it out on YouTube yourself, baby, and see what you think. Let me go through this question, breaking it down. I want to tell all of you listening to me live right now, and even on the podcast, that literally, this is the hardest question I've ever created. It really is, because it's infusing a picture, it's infusing medication, it's infusing EKG, and you have to make a response or make a decision related to, should I call EMS, should I alert the physician, the nursing? It's kind of incorporating all of those very tough concepts all at one time. Yeah, the ones that y'all struggle with. Yeah, I get you. I struggle with it too. So we got Jade is treating a patient in cardiac rehab who is taking spironolactone, lisinopril. and Aricept. So I want to go ahead and slow up there and look at this whole thing saying cardiac rehab. We know that patients who go through cardiac rehab typically have like a myocardial infarction, some type of heart surgery, maybe a heart transplant or a CABG, something along the lines of that. And now cardiac rehab is getting them back to a higher level of function and even getting back to their previous function related to working and so forth, like vocation and exercise and all that good stuff. So cardiac rehab is used for that purpose. And we have this patient who's in cardiac rehab and is taking these 3 medications where I need to slow up as well and go through these puppies. All right, super important. So spironolactone is a diuretic. You need to know it for the NPTE. Spironolactone is a potassium-sparing diuretic. Well, we know that diuretics help us to urinate more often, right? To get rid of a lot of the water content in our bloodstream. But spironolactone is a special one because they call it potassium sparing, meaning that we don't, when we're actually urinating and the kidneys are filtering the blood, they hold on to the potassium, like they keep it in the bloodstream. They don't actually send it out into the urine. So what tends to happen is the patient can build up with the amount of potassium in their bloodstream, creating a condition called what? Hyperkalemia, all right? Oftentimes confused for, I see it every single time. E or D, lock it in. Okay, so I want to dissect these one by one. First one is stop the exercise and alert the rapid response team. Well, this is what I'm getting from this question. That when I look at this EKG monitor, this EKG strip, I'm seeing that tall, what is called like a tall peaked T wave, And what that really means to me is that the patient is potentially having difficulties with their ventricular repolarization. But another way to say that is their ventricles relaxing. They're having a problem with ventricular relaxation. And so here's the thing. When a patient presents to you with hyperkalemia, too much potassium in their bloodstream, guess what is one of the things that you see on the EKG? Guess what? Yeah, that tall peak T wave. Exactly. And so I'm thinking like, oh shoot, I'm seeing that tall peak T wave because the patient potentially is having hyperkalemia. So then I need to make a decision based upon that. What do I do if I look at the EKG reading and now my patient's presenting with signs and symptoms, or not signs and symptoms, but signs, I should say, of hyperkalemia? A says, stop the exercise and alert rapid response team. I don't like that answer. I do like the answer of stop the exercise, but alerting the rapid response team, it's kind of like, all right, Mr. Bill's on the cycle ergometer right now. He's just going and I'm looking at the EKG monitor. I see, a tall PT wave come across and it's like, do I call the rapid response team to come in with the cart and try to revive him or something? No, that's not what's going on. There's nothing in the question that's letting me know that the patient passed out on me or is unconscious or having a heart attack. There's nothing in there to let me know that that's the case. So there's no reason for me to alert the rapid response team right now. All right. I think that's a bit too much overkill. And when the team got there to see you and Mr. Bill, they'd probably be tripping the heck out. All right. So let's go ahead down to B. B says stop the exercise. Again, I really like that. It says place the patient supine and contact nursing. All 3 of those. So I do like stop the exercise, but placing the patient supine, I'm not really understanding that piece. And maybe when would you ever just place a patient supine? What is one of the conditions where you would tend to do that? I mean, the first one that comes to my mind is something like orthostatic hypotension or something, right? But other than that, I'm kind of like, I don't really understand why I would place the patient supine. So that's kind of weird. And it says contact nursing. And I'm like, well, if I ever, and this is important for you to write down in your notes right now, please write this down, that if you ever have new EKG findings, like something new comes up that wasn't in the patient's medical record, it wasn't there before, that's not something you contact nursing about. You actually go directly to the physician. All right? So put that down in your notes. Super important point. If you ever have a new onset of an EKG finding, all right, that the doctor is not familiar with or does not know about, you definitely make sure that you contact the physician immediately. Now, if it's just a PVC, like an isolated one, I can have that right now. That's not a big deal. No, I'm not talking about just one PVC. But if it's a significant EKG finding, then you need to alert the physician immediately. Bottom line, what am I saying? I don't like B. I'm gonna go ahead and eliminate that. Let's look at C. C says continue the exercise, but reduce the exercise intensity, and this is attractive one. This is attractive. Because the question is, well, can I continue to exercise a patient who's presenting to me with hyperkalemia, who's presenting to me with this tall peak T wave? I don't like it. I don't like it. And the reason why I don't like it is if they start to show up with this on the EKG, first of all, we need to get it checked out. All right, we need to get it looked at. The physician needs to become aware of it before we just continue to exercise them. Because can hyperkalemia turn into something significantly worse? Of course it can. If your ventricles are having a hard time relaxing, then you can run into the problem of difficulties with cardiac output, being able to get out enough blood flow in order to supply the demand. And so, you know what? I don't really like the whole just continue the exercise, but reduce the exercise intensity. I really think that we need to handle this whole problem of hyperkalemia. Let's go ahead and put an X next to that. Not necessarily D, but let's take a look at it. It says stop the exercise, which I told you all that I like, and alert the physician immediately, which I would say definitely. If there is this show up of some type of new abnormality on the EKG that is significant, you need to alert the physician immediately. Bam, I think that fits the best. D is the right answer. Now, you may be like, but C, can't you just continue the exercise or reduce the exercise intensity? I mean, how do we know that this is a new thing? Or, is it that bad to just continue with the exercise? And the reason why I don't like C, another reason, is the fact that if we just continue the exercise but reduce the exercise intensity, we haven't done anything
for this reading of the hyperkalemia. Like the fact that that just showed up on the EKG, like we're not addressing it at all. And so that's a problem. And that's something that you can run into on the actual NPTE or your practice exams as well. When they're asking about, something showing up and they're asking you, what would you do about it? You have to make sure that you remember that one of your answers, or the answer that you pick, it has to address the problem. You can't ignore it. So if a new reading shows up on the EKG that's significant, you can't just ignore it and move the other way. I mean, you have to do something about that. And in this case, we're not really addressing that hyperkalemia. Reducing exercise intensity is not going to make the hyperkalemia better. All right. So there you go, y'all. Final answer is D here. Congratulations for those of you who got that correct.
I have seen that question in both the cardiopulmonary tests in the PT program and on practice tests, score builders, therapy ed, and all that stuff. So I'm going to share that in the chat box so you guys can watch it later. Highly recommend Kyle Rice. He's got a lot of good videos out there, and I know a lot of people like his courses that you go through. So we're going to continue going down the EKG rabbit hole with my study guides here. So as you can see, your PVC here. So I have a book called Rapid Interpretations of EKGs. I don't know if there's an ebook out there for it, but I highly recommend it if you're just getting into the PT program or anything like that. But this far in, you wouldn't even have time to get it. But it goes through a lot of the EKGs. So if you're ever in cardiac rehab or anything like that, I highly recommend that book. So I'll share it real quick. By Dale Dubin. So there's the textbook that I'm using right now. So I'm on page 140, 135, 135. So PVC is a premature ventricular complex or premature ventricular. Can't see that, can you? Sorry, guys. So here's the PVC here. So it stands for premature ventricular complex, or PVC is contraction. So basically means that the ventricle is contracting before it should, and it's not as high or as sharp, so it's always prolonged. So you see here is your ventricular contraction. That's a normal one. It's nice and short. So the PVC is real wide, so as you can see here, and the T wave, ST wave is real large there. So if you see a PVC, if you just, like you said, if you just see one or two, that's not a big deal. But I think 3 in a minute or less constitute stopping the exercise and getting some help. So that's all I've ever seen on that. Let me pull up the question. So if you see a question with this EKG strip or any of these EKG strips with 2 or 3 PVCs on there, I would stop the exercise, stop the eval or whatever, and get some help, whether from the physician, like Kyle Rice said, if that's an option, or you don't need to press the code blue button or anything like that. You just need to make sure that you're getting some help with this. So this is typically due to, he was saying hyperkalemia. I thought it was due to hypoxia. So it could be starting with an MI or anything like that. So if you go back over to the difference between a PVC and STEMI and non-STEMI. So you just need to know the difference here. So the ST elevation, so the ST is above the line or depression and it's real long. But as you can see, there is no peak here. So with the PVCs, you've got a sharp rise and a sharp fall here. So it's bigger on both sides versus the STEMI and non-STEMI. It's only that ST wave that's messed up. So going through 6 PVCs per minute is considered pathological, or a continuous run of 3 or more is pathological. So you need to get some help at that point. So it's 6 per minute. All right. So let's go to the next EKG. So wandering pacemaker. Another common one I see is the first degree, second degree, third degree AV block. So it depends on how long the PR interval is. So if you remember the PR interval, so we go back up. So your PR interval is from the very beginning of your P wave. So right here to here, sorry. Let's see. So that PR interval is getting longer, or it's just staying as long. So So if the PR interval is greater than 0.2 seconds, which one block is 2 seconds here, so that's pretty easy to remember. So as you can see here, this PR wave, so here's your P, here's your R. You can see it is almost 1.5. So you know that that's too long there. So, but it's the same. So that's 1, almost 2. So it stops right here. And then from here, that's 1 and almost 2 there. So it's stable, but it is an AV block there. So I think as long as the physician knows that already, you should be okay to continue as long as it does not change. So let's see. So the second degree, you've got type 1 and type 2, which is I don't know how to pronounce that. Mobitz and the W, Winbach. So this is whenever that PR wave gets progressively longer. So it just keeps getting longer and longer and longer. Then it can actually skip a QRS wave. So as you can see here, so it's real short here. So this is a normal PR wave right here. Then you've got a longer PR wave here, a longer PR wave here, and then you've got a PR wave that does not have a QRS, and then it starts over with a normal PR wave, and then longer and longer. Okay, so this is a type 2. So these are the same spaces. So here you've got a P wave, a QRS, a P wave, no QRS, P wave, no QRS, P wave, QRS, P wave none, P wave none. So I think that's a 2-1 QRS wave. So you need to make sure that so every third P wave has a QRS complex. So this is pretty important. So if you see this on there, if you see a bunch of P waves without a QRS wave, you want to get some help. So then we'll go to third degree, which is the most severe. So this is random. So up here, they are getting a QRS wave every third time. So I think it's 3-1 or 2-1. I don't remember what that is, but that's not important. That's way too deep. So 3-1, 2-1. This is normal. You still want to get some help, but it's not a 911 emergency. This one, you've got a random number and some PVCs in here. Like this EKG is just all over the place. So you've got a QRS with not a PVC, I'm sorry. So this is going to be a non-STEMI here. So if you remember up here, this right here, ST depression, that's exactly what that looks like, third degree right here, ST depression, and an inverted T wave. So right here, you've got a ST depression, inverted T wave, P, a long P wave, so you know it's at least a non-STEMI and a first degree heart block because you got a weird one here, and you've got a P, a P, a P. This one is a prolonged RS wave here, and then a PP. So you're going to have to call 911. This is where Kyle Rice's question, if you want to stop and press the code blue or anything like that, if you see this on there, they're probably going to have some trouble breathing. So that right there is whenever you call 911 on the test. I haven't seen that on a licensure exam or a practice test yet. I've only seen, I think, 2 EKGs on all the practice tests I've taken. But so VTEC PVCs and 3 PVCs and less than, I'm sorry. So 6 in a minute, you want to call 911. So this is VTAC, so boom, boom, boom. And you're having PVCs here. So you're having a bunch of QRS waves without a P wave, and you're having PVCs. So of course, this is a 911. This one, just all over the place. I don't even know how to explain this. So this one is, of course, all 3 of these down here are 911. So if you see it all over the place, which this is VFib, okay, so all of the QRS complexes looks like this. It looks like a sawtooth, but it's not the sawtooth of AFib. So if you look at the difference here, these are all QRS complexes versus atrial fibrillation. So you've got a good QRS complex, but you've just got AFib. So you don't have a true, if you don't have a true P wave here. So your atria, of course, your P wave is the contraction of the P wave of the atrium. So if you just have a bunch of random here, it's not symmetrical. This is AFib. So if the doctor already knows about AFib, or if there's a diagnosis of AFib, and if you see this on the EKG, it's not a big deal as long as the patient has good pulse ox, which it's hard to read pulse ox on a patient with AFib. You're going to get a weird reading on heart rate. You might get 210 beats per minute, and then you might get 10 beats per minute. So you want to make sure that you go ahead and measure it with your fingers on the carotid or the or the radial artery. And this is atrial flutter, which is sawtooth. So again, you're going to have that distinction: 1, 2, 3, 4 P waves, and then a QRS pattern. And then 1, 2, 3, 4 pattern, QRS pattern. All right, so I think that's pretty good with the QRS. So one thing is the claudication scale. So this is pretty common with this, so I'm going to write that down up here. So I'm going to write down the ABI scale and the claudication scale because they kind of go together. ABI scale, which is the ankle. So this is whenever you measure the heart rate to the arm, to the leg, and you measure the difference of the blood pressure. Okay, so ankle-brachial index, sorry. So you've got 1 to 1.4, 0.9 to 1, 8 to 9. I don't think I wrote all that. All right, give me 1 second, guys. All right, so ankle-brachial index, you take the systolic ankle pressure over the systolic brachial pressure. So SBP over SBP, and you're going to do ankle over arm. So with this, you're going to have, there's a better scale here. One that determines. There we go. So and I do 0.5 to 0.9, 0.3 to 0.5. So I think I do like anyway. So with this, you're going to have calcification. So that means that the ankle is a lot higher than the arm, so it shouldn't be, because your arm is a lot closer to your heart, so it should have a little bit higher blood pressure than your leg. Here is normal. This is going to be claudication with exercise, and this is going to be resting claudication. So it might ask something along the lines of, let me see. I've got a couple of questions that I've saved. So it may give you like an ankle brachial index of like, let's say 6, and or it might ask you patient is having claudication with exercise, so patient walks around and rates their claudication at a 4, which we'll go over that claudication scale in just a moment. But whenever it rests, it goes away. What is the most likely diagnosis of claudication here? So the claudication scale. So it's going to be a 0 out of 4. So a 0 is no pain, so no claudication at all. So a 1 is discomfort. So 2 is moderate. 3 is intense. And then 4 is unbearable. So I think I've seen this once, question like this on one of the practice tests, maybe 2, whenever it says like a patient is complaining of mild discomfort with walking on a treadmill after 4 minutes. What are you supposed to do? So right here, moderate or a 2, this is your golden number. So this is where you want it to be, as a 2 or moderate. You want to stay right here. So you want to get to a moderate level. Okay. So you can distract them. They say, "Gosh, my legs are kind of hurting a little bit." But so you're in a cardiac rehab, and the patient is there for cardiac rehab with peripheral artery disease. It has been shown that if you take a patient that has peripheral artery disease and put them to a moderate level of claudication, you can actually reverse some of the claudication there, because then the blood vessels are going to dilate and all of that. So if they are saying that they just have mild discomfort, you want to increase the intensity. So increase intensity. And then if it is intense, you cannot, sorry, so this is cannot or anti. That is my shorthand there. So this is cannot or anti, so you cannot distract them. So they are saying, gosh, my legs are killing me. Oh my gosh, they hurt so bad. Hey, so tell me about your weekend. Look, I can't. Like, this is really hurting my legs. Either decrease the intensity to get to this golden number here. This is stay here. So if they're on the treadmill, elliptical, bike, whatever, and they say, yeah, it's starting to hurt a little bit. Okay, well, tell me about your weekend. Oh, yeah, so we went to the beach and all this stuff, and you can distract them. That means that they're right in that golden range. So you want to just keep working at that area for however long. And it takes a little while, I think 20 or 30 minutes. But I'm not sure what the numbers are right now. So, and then, of course, a 4 is, it is just unbearable. So this you need to stop and rest. So this one you're going to decrease intensity or stop and rest. All right, so that is EKGs. We've done cranial nerves. We need to go over validity. Thyroid disorders and the vestibular. Okay, so keep going in the thing here. So, oh, I've got that. Oh, here's the ABI. Look at that, 5 point. Okay. So this is 0.2 to 0.5. So one thing on the licensure exam, if I didn't say it before, they are very good at knowing that there's differences in references and stuff. They're not going to give you a 0.2 or a 0.3 and have you decide between critical and severe. So this is less than less than 0.3. So this is severe, and this is going to be gangrene. So that's pretty low, and they're not going to give you blood pressure and make you calculate that because I don't think you're allowed to have a calculator anyway. So let's see, going through my study guide here. So we went through EKGs. Music. So let's go abnormal responses. So that is one thing. Sorry. That is one thing that's on there is adequate versus inadequate changes in blood pressure. So if blood pressure, systolic blood pressure goes up with exercise, that's common, and as long as it's related to intensity. So if you just keep going up, like if it says you start out on 1 MET, 2 METs, and it goes up to, you increase to 4 METs, and your blood pressure goes up, systolic goes up 20 points, then that's okay. But if your systolic blood pressure goes down, stop the exercise, get some help, call the physician, whatever. So if they sit down and their symptoms resolve, because if their blood pressure goes down whenever they're exercising. So let's do it for instance. So patient has blood pressure resting of 132/84, which is a little high, don't get me wrong, but at, let's pull up METs. I think sorry. So sleeping is 1. Sleeping is 1. So just sitting there watching TV, sitting is 1. And a 2 is walking on a treadmill, level ground, very slow. So if you start them at, they just walked in and they're at a metabolic equivalent of 2. And if you increase it to, like, let's say a 4. So they are walking at 3 to 3.5 mph. Okay, so that's MET 4. It's like MET 3.5 or whatever. Anyway, so that's moderate intensity, and their blood pressure goes up to 156 to 83. Okay, so that is a common and adequate amount of change of the blood pressure. So this can change less than 10 increase or decrease, and it's still okay. And they're not going to give you, they're not going to give you over 5. So if it goes up 1 or 2, I think it's 10. I may be wrong. Yeah, it says 12, 10, 12, something like that. So if it changes more than probably 2 or 3, that's significant. So if it says 83 here, that's common. So if it goes to 73, they're going to start having some shortness of breath or palpitations or something. So have them rest. And if it says that their symptoms go away, stop the exercise for the day, contact the PCP. So if they rest and it does not go away, and if it stays lower, you probably want to call and get some help. So I haven't seen that question on licensure exam yet. So another one might be that it goes down to 122/84. And again, they have symptoms because they're increasing their activity level, but their blood pressure is decreasing. So their muscles are not getting an adequate amount of oxygen. So you're going to again stop, make sure that the symptoms go away, and then continue. I'm sorry, make sure it goes away and then discontinue the activity. All right. A1Cs, I should write that on my labs. There's 7 labs I'm going to write on my paper. The labs. A1C. So A1C So you just need to remember 5.7 to 6.4 is pre, less than is normal, and greater than is diabetes. Greater than. That doesn't make sense, does it? So less than 5.7, 5.7 to 6.4, and then greater than 6.5. So normal, pre, and diabetes. Okay, and I'll go over all that again later. Um, so I need to write these right here. Gotta remember those. So I put a PDF in the chat, and I'm going to go through and write down my chart that I'm going to use on the test. So I don't have it memorized yet, so that's why we're doing it today. So normal, it's going to be green. And you've got FEV1 over FVC, and then percent of expected of FEV1. Nope. And then percent of FVC. So normal is greater than 70%, greater than 80%, greater than 80%. So obstructive means that you cannot get the air out. Okay, so your forced expiratory volume in 1 second is going to be low because you cannot get the air out. You can get a whole bunch of air in, but whenever you start to expel the air, then expire the air, then the bronchioles close up and you can't get it out. So you know that obstructive is blue bloater. So it's going to be less than 70%, less than 80%, but your functional vital capacity is going to be higher because you're able to keep more air inside your lungs at one time. So this is going to be your chronic obstructive pulmonary disease, or your COPDs, your all of that. So with restrictive, you know, there are pink puffers. So they're going to have a higher FEV1 over FVC, so you're going to be higher than 70%. You're going to still be lower than 80% because you're still your volume ratio of how much you can expel versus how much you can hold is going to be higher because you can get the air out real quick, but you cannot get a lot of air out. So the raw data is going to be lower for the functional or forced expiratory volume. You're not going to be able to push a lot of air out, but the amount of air that you push out is going to be higher than the air that you can pull in at one time. And then percent of functional vital capacity is again going to be decreased because you cannot get that air in. So you're thinking like restrictive lung disease. So let's pull up a list of restrictive lung diseases. So lung fibrosis. So you cannot expand your lungs, you cannot expand your alveoli and all of that. So you're thinking like emphysema. So you cannot get that expansion inside the lungs there. Pulmonary fibrosis. So, sorry, the emphysema is still classified as a obstructive lung disease. So your restrictive lung diseases are your idiopathic pulmonary fibrosis, sarcoidosis. So it's just going to be your pulmonary fibrosis. Okay, so here's the questions. Let's pull up the questions. It's not a good one. All right, so let's take a break. All right. Take a 10-minute break. We need a break. All right, see you guys in 10 minutes. All right, guys. Let's go to that PDF I just shared. The one that says pulmonary function test, case questions and answers. And we're going to try to go through all of these. So case study 1. 65-year-old undergoes pulmonary function testing as part of a routine health screening. You guys can read that. All right, so I know there's a lot of numbers here, but we don't need all of them. So let's see if I get right on this. Nope. So let's pull this up. So all I need is those three there. So actual 4.39, predicted 4.32, percent predicted. So we've got FE, FEC. So if we come up here, FEC is on the right, so let's go all the way over here. So FVC is 102%. So now we've got FEV1 and FEV1 over FVC, and this is percent predicted. So FEC is 102% predicted. FEV1 predicted is 95%. And the actual percentage is 73%. So if you remember, FEV1 over FEC, normal is 70%. So he is above 70%. So far, he is normal. Come on, green. Pardon me 1 second, guys. So this is normal. FEV1 is 95%. So as you remember, greater than 80% is normal. So this is normal. FVC, so forced vital capacity, is greater than 80%. So this is all normal. So he has all normal values. And right here is after the bronchodilator change. So there's not a big change on that. So you know that he doesn't have asthma or anything like that. So there's no change. So this is a normal. So not restrictive or obstructive. So you check your PDF and go down. Case 1 interpretation. Patient has a normal total lung capacity, indicating there is no evidence of restriction. Yeah, he has a normal response, so he does not have obstructive or restrictive lung disease. Okay, case number 2. So let's write our numbers. So we've got FEV1 over FEC, FE. So his FEC is 76. Sorry. His actual is 68. So this is low. So already I'm thinking an obstructive lung disease because he is obstructed on trying to get the air out. So let's keep moving on though. FEV1 percentage. So FEV1 is percent of predicted is 64%. So again, this is low. So if you remember, our normal values is greater than 70, greater than 80. Yeah, greater than 80 and greater than 80. So 7, 80, 80. So since it's low, again, I'm thinking obstructive. And FVC, functional vital capacity. FVC is 76%. So it's a little low, but it's not as low as the FEV1. So with this, you've got a post-bronchodilator, and you have a 25% change in the FVC and the and 30% on the FEV1. So that is greater than 12%. So I think 12% is your cutoff. 10 or 12. I don't remember. Yeah, 12%. So bronchodilator change is greater than 12%. Means that it is a positive for a bronchodilator response, which, as it says in the PDF, so I'm going with obstructive lung disease. He has a little bit of both, obstructive and restrictive, because the FVC is low, but I don't think it's low enough to classify as a restrictive lung disease or a combined. Let me pull up my cheat sheet. Consistent with diagnosis of obstruction. So that is correct. So they do have an obstructive lung disease that is responding to bronchodilator. So case 3. Six-year-old man presents to his primary care provider with complaints of increasing dyspnea. Smoked a lot. So it's 40 packs a year. So 52 weeks in a year. So he smokes a little less than 1 pack a week. So let's write our numbers. So let's rewrite everything. So we've got FVC, no, FEV1 over FVC, FEV1, FVC. So normal is greater than 70, greater than 80, greater than 80. Okay. So with obstructive, you've got less than 70, less than 80, and then greater than 80, and then restrictive is greater than 70, less than 80, less than 80. Okay, so this patient has a gray, has an FVC of 41%, wrong place, 41%, but you're already thinking of restrictive lung disease. FEV1 is 25. And their actual is 47%. So they are low all over the board. So if they're low all the way across, this is going to be a combination or combined. They have a, so we can write combined here. I didn't realize there was going to be so many combined. It's less than 70, less than 80, less than 80. That's not 88. Less than 80. So this is combined restrictive and obstructive. So with this post bronchodilator change, you've got a 96% change. So I'm leaning more of the restrictive, obstructive lung disease. It's a big change. All right, and let's go to the, so this is going to be a combined combination of restrictive and obstructive lung disease. So let's go to our PDF, case 3. So there you go. He has obstructive because he can't get the air out, and he's also got restrictive, so he can't get the air in. So this is a combination of the two. Let's see what this one looks like. Okay, this one's a good one. So this is case 4. This will be our last case on the pulmonary function test. I'm pretty sure you got it by now. Okay, so what do? We just write it again. So normal FEV1 over FVC, FEV1, FVC. So greater than 70, 80, 80. And you could just do a negative. So you can write it just like this. So you've got greater than, greater than, greater than. The middles are all greater than. No, just kidding. So this is less than, let me write it out. See? Less than 80, greater than 80. pink. All right, so case 4. So his FVC is 109, which is greater than FEV1 is less than, and this is greater than. So if we follow it up, so sorry, actual is less than. So FEV1 over FVC is 54%, which is less than 54%, which is less than. Or FEV1 actual is 256, so percent of predicted is 69, so that is 69, which is less than. And our functional vital capacity is higher, so it's 109%, of course, and this is greater than. So if you go up, you know that this is an obstructive lung disease because they're obstructing their ability to get the air out in 1 second, and as compared to the functional vital capacity, because the functional vital capacity is greater than what it should be. So 80% is what it should be, a little bit greater than 80%, that's fine. But 109% when everything else is there, so you know that this is an obstructive lung disease, so they can't get it out. So let's check the PDF. And they did not use a bronchodilator, so I would have asked for the post bronchodilator because I bet that this number would go up quite a bit. Airflow obstruction. That's a good way to put it. So that goes in a little bit more detail than what we'd ever need to go into. But I think you've got it. So this is a new one. This is because it actually goes down with bronchodilators. Ooh, FVC is low. FEV1 is real low. Residual volume's high. Total lung capacity is high. FEV1 is low. So everything's low, so you're going to have a combination there. They would never ask you this intensive question on the NPTE though. Alright, so I think we got PVCs done. Okay. So I think we've hit cardiopulm enough. Let's go through the ortho tables. So, of course, this was a class effort. So I just made the notes on here, but these are the tables that we used in our program. So a lot of these. So we need to go over Fryet's laws still. So with Fryet's laws, so with the thoracic and lumbar, you've got side flexion and rotation, or side bending and rotation in neutral and flexed or extended. So with neutral, I saw this diagram a couple years ago and it works out real well. So neutral, it's going to be opposite. That's with the thoracic and lumbar. So if they side bend to the right, they're going to rotate to the left. Same thing. Side bend to the left, going to rotate to the right in neutral. But if they have a flexed spine, you've got flexed, which is the same, and extended, which is the same. And there was a couple of questions on that through my practice tests. So, but the cervical, there's a lot of resources that say one versus the other. So, let me pull it up. So cervical from C2 to C7, they are the same. So the only ones that are different is the thoracic and lumbar in the neutral location. So I don't know if it delineates for flexion and extension in the C spine. So, oh, it says right here. So I'm on this website. Okay, this is where I got the information on the C1, C2, and C2 through C7. So I did have one question on the cervical spine. I don't think I got it right either. But, so if it asks for side bending and rotation in the cervical spine, it's going to be in the same direction. Okay, and on the same path as orthopedic testing, so the vertebral artery test includes the same side as rotation and flexion. So if it says that that you are doing, because they don't say just vertebral artery test, it explains the test or it gives you a picture of the test. So it's extension, side bend, and rotation. So it's going to include the same side that you're on. So let me pull up my notes on that. So So, again, I'm getting conflicting information here. Physiopedia, so I'll share the website here, says it's on the contralateral side. All right, guys, I think that's enough for now. Tune in next time, and we'll probably go over a lot of stuff again. So if you guys have any questions, hit the comments, and happy studying. Till next time.